Okay, the outline is why is MOOP being subtracted? Why was it subtracted in the NAS measure? Why does it continue to be subtracted in the supplemental poverty measure? So the key is how to define and measure health care in poverty measurement. Okay, the whole idea, I keep going back, the NAS says it's to, the purpose of the threshold, NAS, was to provide for needs. And we so happened that the NAS and then following the interagency technical working group, so we use it with spending. We deal with spending. But because there were all these issues with medical care, we said, well, you know, let's treat this differently. You know, Marilyn Moon addressed this in quite some detail in a report to the panel. But basically, we were left with the fact that we were going to subtract MOOP expenditures from resources instead of having it in thresholds. But I'm going to be talking about two different approaches, and that is to include some value for health care in thresholds. I think the subtraction of MOOP from resources has been hammered through the floor, so I'm not going to deal with that. I'm going to deal with including health care in the thresholds. First one is including expenditures. Another one is including a universal basis plan and thresholds and with adjustment to resources. I think one of the reasons that Daria is excited about this is because it's based a lot on the work that she and Sanders have done. Okay, so bottom line. Okay, to me right now, okay, are we treating healthcare as a need or are we treating it as a tax? A lot of people say, okay, the subtraction means that you can't use those resources to pay for food, clothing, shelter, and utilities. You know, taxes, some people don't pay taxes, and taxes are very skewed as well. So implicitly, by subtracting those from resources, we're actually treating MOOP as a tax. All right? People who have a lot of deductions, you know, they don't pay as much tax. People who decide to have plastic surgery have a greater deduction of MOOP. Okay, there's some issues here. All right, so let's say we're going to say health care is a need. All right? Then the practical issues, we're going to look at expenditures in thresholds. We say, okay, let's add expenditures, out-of-pocket expenditures, MOOP, along with food, clothing, shelter, and utilities at the micro level. Look at the 33rd percentile, you know, versus the median or percentage of the median. And then we can, another one is if we have a basic plan, can we value that basic plan and what would we have to do? All right? So, why is it subtraction? MOOP is non-discretionary, it reduces those resources. Again, it's treated like a tax. In my understanding, the way I look at it, it's treated like a tax. Say, oh, we've got heterogeneity in healthcare needs. Well, you know, we have heterogeneity in taxes. All right, medical risk. Okay, now that is a real concern. Medical risk in terms of health insurance, medical risk in terms of your health status. All right? And if we included this in thresholds, we'd have like thousands and thousands and thousands of thresholds. But how many thresholds do we have right now, Trudy? How many thresholds? With geographic adjustment.
Oh, with the geographic, yeah, 3.
How many? 1,000?
Yeah, maybe, yeah.
About 1,000 thresholds right now. 3, okay, all right, here we go. So that's not really our concern, you know. And there's a question, how do you value healthcare needs? And again, we have to still consider consistency in thresholds and resources, right? Basically, at the time of the National Academy of Sciences report, and even following years, even in, you know, with the interagency technical working group, you know, there's no agreement on regarding how to define these. We have no national health insurance. And so how are we going to measure these with data available? Well, guess what? We do have state exchanges for some states, all right? So that's changing the picture a bit. So what are we doing now? The NAS and SPM subtracting MOOP from resources, like I said, like a tax. There's no impact on the thresholds, none at all. And the whole idea, the recommendation by the panel in the agency technical working group is there will be a separate medical risk index. And some colleagues from the Census Bureau have recently published a report, an article, a manuscript where they developed something like this. All right, but what if we included it in thresholds? The real drive behind including it in thresholds was portability. Problem is, most surveys, current population survey, ACS, et cetera, at the time of the recommendations, did not collect MOOP. Now, CPS does. That was actually a big driver by David Johnson when he was there to get those questions added to the CPS March supplement. But it's still not collected in the ACS. But Richard Bevere, who is not with us anymore, he really, really pushed that. He said, you've got to have portability of your thresholds. Got to have portability of your thresholds. We went to meetings with people at the state level who work in the state welfare offices. We've got to have thresholds that account for health care. We've got to have portability. We heard it. So we said, okay, so what are we going to do? So Kathy and I, with Jessica Banton, early on, worked with including medical out-of-pocket expenditures in the NAS thresholds. And I'll show you some results of that. More recently, some work by Sanders and Dahlia have said, well, let's look at the idea of basic health insurance. The need is not medical expenditures. The need is health care. And what is our best way to get health care provided is through health insurance. Because if you look at a health insurance premium, part of it is pure insurance. The other part is the expected cost of your use of medical goods and services. That's what insurance is. And if we go with this last option, it's going to affect thresholds as well as resources. If we go to MOOP in the threshold, we're not making any change to resources. And we are actually we've done research on adding MOOP to FCSU in the supplemental, and Dahlia and Sanders have recently published a National Bureau of Economic Research study on the other approach. Okay, so here, what is needs? In MOOP, it's food, clothing, shelter, utilities, plus out-of-pocket expenditures, which includes your premium, if you pay a premium for health insurance, at the micro level. Then you take the distribution of your consumer units, and you look around the 30th through the 36th percentile to get your estimate. Then you take the percentage that's for medical, and you apply a medical risk index to that part, because you can't apply the same three-parameter equivalent scale, because there are differences in health insurance and health status. There are differences if you've got children, if you've got elderly people, so you have to make an adjustment for that in your threshold. So as I mentioned, with the NAS, Kathy and Jessica Banton and I did some work with that early on, and then Kathy and research assistant Marissa Gudreas and I have done some more recent work with it in the SPM. And as I said on the other one, if we look at using or defining need as health care with the proxy being the value of health insurance, you would actually include a value or the full cost of a premium. Okay, then what happens with resources? Like I said, if you're adding it in as the part of the thresholds, there's no adjustment in the resources. However, if you add the value of health insurance, which is your proxy for health care, in the thresholds, it's going to have an impact on your resources as well. There are going to be some additions, and there are going to be some subtractions. Okay, so what kind of data do we need? If we've got MOOP in the thresholds, premium paid, expenditures for discretionary and non-discretionary, we don't ask in the expenditure survey, and neither does the Census Bureau and the CPS, ask if this expenditure is discretionary or non-discretionary. MOOP part of the threshold, as I said, is adjusted by the medical risk index, so we have to come up with a medical risk index as well. And again, no impact on resources. A health care in the thresholds, there has to be some universally provided plan that is socially defined as essential. So there has to be a decision by some politic that says health care is a need. Some states have accepted the Affordable Care Act. They say health care is a need. For people at the lower end of our distribution, health care is a need we've identified for people who get Medicaid. For the elderly, we say health care is a need if you're 65 and over, right? But the ones in the middle, not, all right? But you need some kind of universally provided health care. It covers non-discretionary, It's not based on health status. It's community rated. It means that you cannot be denied coverage because you have cancer, for example. Resources, how it's impacted, you add the value of the plan premium to your resources, subtract any premiums that you have to make out of pocket. You add any subsidies, which would actually be your plan premium. And let's say you get a state exchange, you're in a bronze program, and you get the full value subsidized, so that's going to be the value of the premium. You don't pay any premium, so there's not going to be a subtraction, so your net is going to equal the full value of the premium. And you can subtract any non-premium MOOP with a cap. Each insurance plan, medical insurance plan, has a cap on what the family is required to pay out of pocket. All this information is available at the state level. Okay, so what do we do with MOOP and the thresholds? We apply the 3-parameter scale to food, clothing, shelter, and utilities, and then we apply the medical risk index, or what I call a medical equivalent scale, to the other part. All right? And I said this index is based on the number of people, presence elderly, what type of insurance people in your household are covered by. Okay, for the NAS work we did, we actually made an adjustment for the uninsured, but for this most recent study, we did not. Okay, these are the thresholds. We've got FCSU-M, that's when medical expenditures are included in the threshold. That's in blue, and the red is just FCSU, and then the green is the official. So you can see the relative difference when we include out-of-pocket spending in the threshold. Now, what happens with poverty rates? The blue is medical subtracted from income. Poverty rate comes out to be 16.1% versus included in the threshold, 14.7%. Well, we know conceptually that if you subtract it from resources that are added to the threshold, you should get a very similar poverty rate. So what happened? Let's look. We're comparing 2011 results, which I just showed you, with when we did the same thing with the National Academy of Sciences result, and a measure. And we find that it doesn't matter if you subtract or add MOOP when you're using the National Academy of Sciences measure, but it does if you're using the SPM. Now, why is that? Well, number one is percentage in the distribution. This is very important. Remember when I talked about earlier about, one of these legislative aides said, okay, I'm going to tell you where that 33rd% came from, certain percentage of the median. Oh, well, then let's get a percentage of the median who understands that. Let's just take 33rd. This is one reason why that point in the distribution really matters. Also, you've got a different group of units of your estimation unit. All right, so if you look at this, this is the distribution of consumer units with 2 children by our medical equivalent scale groups, 33rd to 36th percentile. You see with MOOP share of 2 adult, 2 child equivalized FCSU, it's about 8.1%. And in this part of the range, we've got 60% have private insurance, 22% have public. So about 82% of the consumer units are covered, SPM units are covered at the 33rd. If we look around the median, MOOP share is 9.8% of the total of the threshold. Private represents 76%, 12% public, so 88% are covered. So one reason when we're getting about the same percentage of poverty at the NAS, which is based on a percentage of the median, versus the 33rd percentile for SPM, is because there's a very large percentage with private health insurance, and they're paying an out-of-pocket premium. All right? So, and these are the dollar values when we're talking about what is being added to the threshold. Okay, another approach is the health inclusive poverty measure that Dahlia and Sanders came up with. Right? I mentioned these a little bit. They talked about the idea in their 2013 National Bureau of Economic Research report. And then in 2016, they actually went through an implementation of this with Massachusetts data. And they do it, though, for units where there's no one greater than or equal to 65. All right. So the idea is you add the unsubsidized premium, add the net value of insurance, It depends on if you qualify for a benefit or if you have employer benefit or if you had Medicaid. All that matters, okay? So the basic plan, they use the cheapest Massachusetts bronze plan, which is closest to the silver plan today, all right? Like I said, they only have people less than 65 in their sample. And so here, this is an idea. They say, okay, you've got the thresholds, and you add in the value of the plan, okay? By the bottom, you see the person with the plan, not poor. The person without the plan is poor, all right? So then they, give you some poverty rates. Okay, you can also, for states that don't have these plans, you can actually use a Kaiser Plan. So if your state is interested in looking at the impact of health care in your program, you can use your state exchanges, not only to get the value of the plan for the threshold, but also what you need to add for the resources, because you're going to have that data. You're going to have the out-of-pocket, you're going to have their premium, and you're going to have their benefit. For those that do not, you can at least get a threshold using the Kaiser plans. But I'm not quite sure what you're going to do for your subtractions and additions on the resource side. You can at least come up with the thresholds. Thank you.